It's my proud privilege to introduce KP Paulose sir, who is the Chief Physician and Principal Consultant in Medicine at Sri SUT Hospital. And he is also the Emeritus Professor of Medicine at the SUT Academy of Medical Sciences, Trivandrum. He graduated in the year 1958 and he did his MD in 1964, and he also has a diplomate of the American Board in nuclear medicine. So he started his career as a tutor in medicine at the Medical College Trivandrum, and later on in 1966 he became the assistant professor, and further during the tenure here as assistant professor he went to US and trained in Johns Hopkins University to get a fellowship in nuclear medicine. He was instrumental in starting the thyroid clinic for the first time in the Medical College Trivandrum, and also at that time the isotope division was started, and he was a consultant in the nuclear medicine department of Regional Cancer Center Trivandrum during the 90s, that is from 91 to 2000. And he has several honors and memberships to his credit, which includes fellowships of the Royal College of Physicians, American College of Physicians, American College of Chest Physicians, and so many which runs into pages, in fact. And he has been holding several positions in several learned societies, which also is a long list. And he has received several awards, which includes Lifetime Achievement Awards. And he has about 120 publications and several firsts to his credits, which includes the first person to be deputed for training. So with this, I request so above all the accolades that he has as a scientific, as a scientist and a teacher, he's also a literary figure. Actually, he had started writing during his training days, and he used to write articles in dailies and other places in a pseudonym, and he has published books in Malayalam, several of which were related to health issues. He has several chapters in books, and currently he is a principal investigator of several funded trials, which is at its phase 4, and several of them he has finished. With this, I will go to the session straight and call all the chairpersons. I'll call Dr. Sen to come first, and then Suma madam is there. Dr. Sen will give a brief description about the speaker, and Dr. Madhu, moderators Dr. Madhu, Dr. Jyoti and Dr. Sri Jaya. So with this, I will invite Dr. Sen to introduce the speaker. Dr. Binu Luke, who is going to talk on tackling HIV and TB, a South African experience. Sorry. Inviting Dr. Binu Luke also onto the stage. He can take.
Hi. Dr. Sudhindra Ghosh as chair. Thank you for giving me this opportunity to come. My name is Sen. I came here just to attend Binu's talk, and suddenly people said, oh, somebody should talk about Binu. It gives me great privilege to talk about my classmate. In fact, I owe a lot to Binu. I wouldn't have gone into medical school if not for Binu. So I'll tell you the story. In 1984, I joined one of the tuition homes called Winners Academy. And after the first set of exams, obviously I didn't fare very well. So the Scaria sir came and said, see, look at this paper. This guy has topped the class. His name is Binu Luke. Either be like him or forget about your dream. So anyway, somehow it clicked, and I said, okay, I should study something rather than chatting among all the friends. I started studying, and I got into the medical school, and then I came to know who Binu Luke is. And that was way back in 1984. And yeah, very, very brief. Binu has achieved, can you put the Binu slide on? Binu has achieved many things after completing his MBBS and then continuing to do MD in 1994. He has gone to South Africa, and his passion for teaching students, that is shown all throughout, taking a detailed history and telling students and bedside teaching, that has been evident of Binu's hallmark of teaching. And he has gone on to become a professor, and currently he has continued to do and address the medical school and continuing to develop the further medical education in South Africa. With that, I'm very proud to welcome Binu on behalf of all of us in 1984 batch.
Thanks, Dr. Sen, my friend, for introducing and for the kind words. It's a great honor and pride to stand in this auditorium that we have frequented between 1984 and 1994 when I left. And I would like to thank John Panikar sir, Vinay Kumar sir, and the team for giving me the opportunity to come from the global south, because I know that most of the discourses today has been dominated by the global north. So I will add some flair from the south. I would also like to say that, KP Paulose sir, you haven't taught me during that period while I was in medical college here, but early in 2000, I gave a talk in SUT, and I distinctly remember that you were there to encourage me as a young specialist when I shared my experience of early experience in South Africa. So introducing South Africa to you, it's one of the BRICS nations, Brazil, Russia, India, China, and South Africa, which is a country which has got rare gems and precious metals like gold, platinum, and diamond, which shaped the new South Africa, which has a population of 65 million people, dominantly over 50% females, but a young population with less than 5% who are over the age of 65, mostly due to the pandemic of HIV and TB, which ravaged the country in the early 2000s. It's a middle-income economy, but it has high Gini coefficient. That means the gap between the rich and poor is very profound, and mostly due to the system of apartheid that was prevalent for 50 years, and the country got freedom in 1994. So if you look at the life expectancy has increased in the last 20 years from around 50 years to 69 years. You may wonder compared to Kerala, but where it started, when the HIV epidemic started, and with the rollout of the antiretroviral therapy, it has done well in achieving an average life expectancy of 70 years now. High unemployment rate is the biggest problem, because the population, the dominant population, 80% of the population being black, not being allowed proper education during those days, and they have high unemployment of about 30 to 40%. But if you look at the white and Indian population, the unemployment rate is very low comparable to any other developed country. So the quadruple burden of diseases is the problem in South Africa, with cardiovascular diseases, hypertension, diabetes, and obesity is a big problem, along with infectious disease, mostly being HIV and TB, maternal and childhood diseases due to hypertension in pregnancy, and high neonatal mortality rate. And also, some of us may be very skeptical to come to this country because you think that this is a very violent country. Yes, there is violence, but I would, at the end of the talk, convince you to visit South Africa for those of you who haven't visited yet. The public health system, 84% is funded through the state, as in our public health system, with a pyramidal referral pattern from primary health care, community health centers, district hospital, regional hospitals, tertiary hospitals, and central hospital, and a very strong private sector, but catering to only 16% of the population, which are funded through medical aids like the American system. It functions exactly how the American health system works on the private sector side. Medical education, the production of doctors are done through 10 medical schools under various universities. I'm a faculty of the University of Witwatersrand, based in Johannesburg. For some of the physicians, those who have read the ECG textbook of Leo Shamroth, he was a professor of medicine at the Wits University, and his son was also a cardiologist. But we are now establishing the 11th medical school, and I'm the project lead of this medical school, which we think we will start in 2028 with the Northwest University Medical School, named after the apartheid stalwart Bishop Desmond Tutu. Is a Nobel laureate, and because he was born in the place where I work, we decided to name this medical school in his name, the Desmond Tutu School of Medicine. If you look at the HIV pandemic, which started in the late 90s and early 2000, where ARVs were rolled out in 2003, you can see that the incidence have come significantly down of the use of ARVs. And the prevalence now in the age group 15 to 45 is around 16%. But if you actually give ARVs and people live, the prevalence will be high. So it will not come down. If it comes down, it means that those people are dying. But there are various problems that is associated with the management of HIV in the last 20 years. We had to handle the issue of stigma, confidentiality, and denialism, especially from that came from the ruling party and the president of that time, who did not accept the fact that HIV was caused by a virus. It was more of a syndrome that was related to poverty. You know that sexual behaviors propel transmission, and mother-to-child transmission was an important concept, because if you cannot stop mother-to-child transmission, that means the next generation through vertical transmission develops HIV. And the issue of who should be tested, voluntary counseling and testing became the norm, and informed consent was important. If you now see, because the prevalence is so high, when we start our ward rounds, we will say that this patient is HIV positive or not. That's how we would then start a ward round, because that differentiates between the issues that we'll have to deal with in a patient. We had preventative strategies of ABC, abstinence, be faithful, and condomize. The healthcare workers always had access to post-exposure prophylaxis following needle stick injury. Those days, obviously, there was skepticism, but now nobody really cares. There's no problem in managing HIV-positive patients. We also have pre- and post-exposure prophylaxis for casual sex and other activities, which can also cause spread of the disease. Well, in the early days, before ARVs, our aim was to diagnose the comorbid conditions and opportunistic infections that's associated with HIV. But with the consistent availability of ARV through a national rollout program, the incidence of those opportunistic infections have significantly decreased. Obviously, treatment was initially individualized when ARVs were scarce and there were only a few groups of drugs that were available. But now we have standardized regimens with fixed dose combinations for HIV positive patients. We obviously have to know about the side effects and drug interactions. And obviously, what bothers us is the morbidity and mortality associated with HIV. And there has been significant reduction in mortality and morbidity since the introduction of ARVs. In fact, with ARVs, it's one of the easiest diseases to treat once the patient is compliant on the single pill. Obviously, going through the opportunistic infections, various with diarrhea, either due to HIV enteropathy, malabsorption, various infections from CMV, colitis, to specific AIDS-defining organisms like Isospora belli and Cryptosporidium. Meningitis, dominantly tuberculosis with its various manifestations of central nervous system tuberculosis, including space-occupying lesions of tuberculoma, cryptococcosis and cryptococcal meningitis. TB in its various manifestations is a reinvention of disease processes, with almost every system being affected through disseminated and extrapulmonary tuberculosis. specific pneumonia that we have to manage, which is a hypoxic pneumonia, the pneumocystis jirovecii pneumonia or pneumocystis carinii pneumonia. Kaposi sarcoma produced by herpes simplex 8 virus, which is an angiomatous tumor that occurs in the body and in the lymph nodes. You have higher incidence of lymphoma, especially the non-Hodgkin's variety. Intracranial space-occupying lesions, dominantly lymphomas, toxoplasmosis, and tuberculomas. Involvement of the kidney, dominant reason for renal dysfunction is dehydration associated with diarrhea, but it can also affect the kidney in terms of HIV-associated nephropathy and HIV-associated immune complex disease. I was very excited when I first joined South Africa. The first thing that I asked my superintendent, because it only had sonar machines, was to buy me an echo machine. I came back and Girija madam taught me further skills in echocardiography. And, when I was amazed at the amount of pericardial effusions that I saw, either due to HIV or TB pericarditis with effusive constrictive pericarditis and constrictive pericarditis, and also HIV cardiomyopathy. This was a patient, Paulose sir, I actually presented in SUT that day. So it was in the early 2000s. This patient came with a right lower motor. I wouldn't do a class now. It's a right lower motor neuron facial paralysis with a right abducens palsy on the right. And also the patient had ataxia on the right side, cerebellar ataxia. So we concluded that the lesion is somewhere in the cerebellopontine angle, and the MRI shows that there is a specific lesion, the CP angle, an intraaxial lesion with other lesions in the cerebellum. The IgG toxoplasma was positive, and this turned out to be cerebral toxoplasmosis. The patient did very well on high doses of Bactrim, and subsequently the patient was put on ARVs. I took the photograph with his permission, and the patient actually did very well on ARVs. So tackling HIV, we have multiple drugs now available of various groups with nucleoside reverse transcript NRTIs, NNRTIs, protease inhibitors, integrase inhibitors, fusion inhibitors, capsid inhibitors, GP120 attachment inhibitor, CCR5 antagonists, monoclonal antibodies, and pharmacological enhancers. And you have a list of those drugs. I'm not going to read it. Now we have very standardized fixed dose combinations. The standard therapy used to be tenofovir, efavirenz, and emtricitabine, but has been replaced by dolutegravir-based regimen, or we call it TLD. And in alternate therapy, if you have renal dysfunction, you can have an abacavir-based regimen, or if you have renal dysfunction, you can use tenofovir's variant prodrug, the alafenamide. And the second-line regimens are protease inhibitors based, and third-line regimens with darunavir and other protease inhibitors that can be used in case of viral resistance. So the national strategy is called the 95-95-95 strategy, which is a WHO strategy where if you're HIV positive, 95% who are infected with HIV must be tested, of which 95% should be on treatment, and of which 95% should have viral suppression through their entire life. And South Africa has achieved a testing rate and positivity rate of 96%, but only 78% people are on ARVs, of which 93% of them are virally suppressed. So that tells volumes of the national ARV rollout program, which is the biggest in the world with over 6 million people, but there is a gap of about 1 to 1.5. There is a drive now to put those people also on ARVs. There are newer drugs that is available, like that I mentioned is lenacapavir, which was developed for the HIV-resistant mutants, but this was also tried in pre-exposure prophylaxis. Is an injection that needs to be taken once in 6 months, and there has been a 96% reduction in the incidence of HIV in this particular group, and this holds promise in reducing the incidence and thus the prevalence of HIV moving forward. There has been many attempts to develop a vaccine, mRNA and otherwise. We have not yet there to produce a vaccine, and there are also newer drugs, monoclonal antibodies that is being developed. This was a study that was done in Johannesburg, where this formed the basis of shifting of the regimen from TEE or efavirenz-based or tenofovir efavirenz-based regimen to TDF or tenofovir FTC dolutegravir regimen. And there were 3 arms for this study. This was also to look at comparing tenofovir alafenamide versus the standard disoproxil. Tenofovir alafenamide was found to be good in terms of viral suppression, as well as both the TDF regimens had high viral suppression, which was sustained at 48 weeks and 96 weeks compared to efavirenz, but there was no statistical difference. The important thing was the side effect profile in terms of viral resistance, because there is a higher incidence of viral resistance in patients who do not take their medicines against efavirenz. And we found that the people who are virally resistant and were put on the trial in the DTG-based regimen, or the integrase inhibitor dolutegravir-based regimen, the resistance was negligible. But tenofovir alafenamide had a problem of weight gain. So the TDF-based regimens had weight gain, with the alafenamide one have a higher weight gain, more in females and than in females. Both gain weight, and that would also, the fat deposition was more truncal, and it would produce cosmetic problems. So alafenamide is now reserved for people who have renal dysfunction or osteoporosis, which are the side effects of TDF. So the regimen now is TDF, 3TC, and dolutegravir. So that's the appearance of metabolic syndrome because of the weight gain and insulin resistance that's associated with these drugs. So at the end of 96 weeks, it was concluded that TDF will be the first-line regimen, and alafenamide will then be reserved for patients with osteoporosis and with renal dysfunction. The study was continued to 192 weeks with the people who were willing to continue with the trial. And it was then determined that the weight gain then stabilized from after 96 weeks to 192 weeks, which is a good thing. And the viral suppression continued. So that then confirmed that this is going to be the regimen for some time to come. Moving on to tuberculosis. You know, it also has a problem, South Africa also have a problem of tuberculosis with high prevalence and incidence, very much coupled with the incidence and prevalence of HIV. You know that each disease promotes the other in terms of the manifestations and the severity, and obviously with adherence, increased risk of resistance. So they feed each other. And it was important that HIV and TB are managed together. You know that when you have TB, especially the severer forms of TB, the first aim is to treat TB for 2 to 4 weeks and then introduce the ARVs, even though there's a risk of immune reconstitution syndrome. So you can see that the coverage of TB coverage through the National TB Control Program, exactly like what in India is, has taken off the ground with more than 80% coverage on TB. And you can see the significant decrease in the incidence of tuberculosis. And that's because, you know, South Africa is also a very developed country in its parts, and majority of the place is very developed. So systems are in place, even though we have to serve a large, poor population. So TB diagnostics are done through the National Health Laboratory System, which is the public health laboratory system through the entire country, well documented to get and retrieve results available on our lab track. So we have got advanced diagnostics. AFB has been replaced by Oromine many years back, and GXP was introduced when it was available, and it has got various line probe assays as well as the phenotypic TB culture. TB regimens for sensitive and drug-resistant TB are available and accessible to the population through fixed dose combinations through the National TB Control Program. So you can see that from 2020 to 2023, there has been, and so even the coverage, even though the coverage has increased, so let me get to this slide. There is one column that's missing, that's called pre-XDR TB. This is the old definition of MDR TB, where somebody had to be resistant to both rifampicin and INH to call it drug-resistant TB. Now we call it rifampicin-resistant TB, which is MDR with or without INH resistance. The key is rifampicin resistance. And when it comes to XDR TB, they have coined a new terminology called pre-XDR TB, where there is resistance to rifampicin and one of the drugs that define XDR TB, which is quinolone, or the aminoglycosides or the injectables, capromycin, amikacin, or kanamycin. And XDR TB is when you have resistance to all these three drugs. Next study was done in our hospital, part of the study, where, this next study was the introduction of newer agents in the treatment of MDR-TB, because the usual treatment of MDR-TB is long with the injectables, and you have to institutionalize the patient, and it's over 18 to 24 months. So various efforts were made to reduce the treatment time for XDR-TB. The next study regimen used levofloxacin, bedaquiline, and linezolid. Bedaquiline, the problem is you have to monitor the QT intervals for cardiac toxicity, and linezolid at higher doses have toxicity producing retrobulbar neuritis and peripheral neuropathy, and that at doses of 1,200 milligrams, which is a Staphylococcus aureus specific antibiotic. But then a second study was done in our hospital, in our MDR-TB unit, using bedaquiline, pretomanid, and linezolid, which had 4 arms in the study, with different duration of linezolid, as well as different doses of linezolid, to see what is the lowest dose that can control or have a treatment success in terms of culture conversion in XDR-TB. And it was found that the study was very useful in reducing in the 26-week regimen, which is basically 6 months. We were able to now reduce the treatment for culture conversion, and it was as promising even with a dose of linezolid at a lower dose than the 1,200 milligrams. 600 milligrams for 24 months was adequate to have culture conversion. So this has also resulted in the incidence and prevalence of TB decreasing, but you can see that there is a slight increase between 2020 and 2023, and this can be attributed to the other pandemic that all of us had to lead with, which really disrupted the health services in most of the countries, and you can see that there is an increase of morbidity as well as increased incidence of tuberculosis, and we hope that now that the health systems are back, while we wait for the next pandemic, hopefully, we can tide over the situation and turn around the situation. Just a few words about the medical school that's going to start. And yesterday I had a short discussion with the Vice Chancellor, because we would like to enter into agreements with the university here. So this is in Northwest Province. The medical school will start in 2028 with 80 students, increasing to 150. It's a very interesting curriculum. Medical education, or MBCHB, that we call in South Africa, is over 6 years, and we have an internship over 2 years. And I was very much involved in the introduction of the modified two-year internship program through the Health Professionals Council of South Africa, that the district hospitals as well as central hospitals are part of training. This is an integrated, vertically integrated and horizontally integrated curriculum. We have identified 140 common presentations as the basis of development of curriculum from year 1 to year 6, because a patient comes to you and does not give the diagnosis but will give you the presentation, and the student should be able to figure it out. So that will be the basis, with early clinical exposure to patients' homes in year 1 through the district health system and the tertiary and central hospital system during the 6 years of training. For those of you, this is my last slide. I understand that the Alumni Association under Dr. Panikkar is planning to visit South Africa in spring. This is the place where Mahatma Gandhi was there for 21 years, where he turned from an ordinary barrister to a Mahatma because of the experience that he had in South Africa. And this is his Satyagraha house in Johannesburg. And as you go through the different parts of South Africa, you will see where Aishwarya Rai was crowned Miss Universe in Sun City, which is very close to where I live. And then you can go through the Cape Winelands, taste good wine, see Robben Island, where Nelson Mandela was imprisoned for 27 years and came out with an attitude of reconciliation, which made a peaceful transition from an apartheid regime to a democratic nation. You will also see the tribal dance of the Zulus and the Big Five in our game drives. So thank you very much for this opportunity. That's the statue of Nelson Mandela overseeing union buildings, which I showed in the first slide, which was the architect of union buildings was the same person who designed the Indian Parliament, Sir Herbert Baker. So this was we were all British colonies, and that's why we have the similarities. And this is the picture of the university that I will be working now to develop this new medical school. Thank you very much.
Thank you, Dr. Binu, for the excellent coverage of the topic, which include the cursed duet, we call it, TB and HIV. And most of the drug trials we learn from the South African trials, for both for HIV and TB. And
Yes.
we are lucky because the Living Legend lecture is presented in front of the Living Legend. So all of us thank the organizers for giving us an opportunity to interact in this session. So he has covered almost all the important points related to TB and HIV. If you have any burning questions, I think he is the best person to clarify those things.
Yes. I would like to make one comment which I wanted to. There were a lot of accolades given to our teachers, and I also would like to give my my respect to Vijay Lakshmi Madam. And the reason why I did not subspecialize was her. And her mind as a detective mind and how she conducted ward rounds always stimulated me and encouraged me and motivated me. Thank you, Madam. I'm sure she is in the house. And it was also quite befitting that she received a lifetime award, and I also received an award. So I'm very thankful to this medical school for having given me the opportunity. Thank you.
Any contribution from our coordinators?
What is the prevalence?
Moderate. Yeah.
What is the prevalence and what is the compliance rate in Africa?
So Africa is a very, very big continent, and South Africa is in the southern tip. It's one-third the size of India, but with a very low population. So the compliance in South Africa is quite good, and that's why I said that in HIV there's a 93% compliance and viral load suppression on the patients, on the 6 million people that are on ARVs. So Africa is, I wouldn't be able to talk about the rest of the nations. Obviously, they are not as endowed as a middle-income country like South Africa, and they will have specific. But sometimes it's not always the resources that is the commitment of the healthcare worker and the commitment of the patient to take treatment that makes it happen, and not always the resources. But I will not be able to comment on the other African countries.
What about the prevalence of TB? Is it coming down? Is it coming under control?
Yeah. So it is coming down. At some point when HIV was at its peak, we had about 600 per 100,000 new infections of TB, and significant reduction since the introduction of both ARVs and TB treatment.
So now you feel the national TB program is doing very well, and the TB is coming well under control.
Well, because, we had, my hospital had an MDR TB unit, which is a 96-bedded unit, of which 20 beds was dedicated to XDR. And patients used to be admitted for at least 4 months with amikacin injections. And now we do not have the XDR TB unit because it's no more necessary, because we don't diagnose XDR anymore because of the short course bedaquiline-based regimen that we have started.
Here also our national program, we are giving bedaquiline. But things are vastly different in India. The compliance rate is poor and people are reluctant to take. They are going to where the camps is doing a lot of business. And we have introduced the TB program, National TB program 1962. 1997, the RNTCP, Revised National TB Control Program came. 2020, we have launched the NTEP, TB Eradication
Elimination Program.
Yes, but I don't think it is possible, considering that without compliance, TB can never be controlled.
That's right. So in South Africa, whether you are a paying patient or a rich patient or a poor patient, if you want to get TB treatment, you have to go through the government system. That's number one. Second point is, we have a shortage of doctors. And we decided that it will be nurse practitioner led, even though there may be certain problems with lack of doctor-led service. But in terms of running programs, it overall as a public health intervention, getting nurses to do it is much better than doctors monitoring it. And the South African patient is quite a compliant patient and not a complaining patient. So if we can ensure that they can come to the clinic every week, we can ensure that there is adherence.
Thank you very much for Dr. Luke. It's a very, very enlightening talk, so thank you very much for the chairpersons and moderators for,
for sharing your experience. Now let us hear something from our legend.
No, because we're short of time, so I think we're only short of time.
My dear colleagues, students, friends, ladies and gentlemen, the only eligibility for me to become a legend is because I think I am the senior most alumni of this medical college today to attend this function today. Although I belong to the fourth batch, I cherish memories of my teachers who departed, and also cherish memories of people who are living but could not attend. Namely, Dr. Krishnadas, Dr. Leelamani Ambrose, who belonged to the first batch, Dr. Ambika Atmajan, Dr. Vas Menon, Dr. Raman, who belongs to the third batch, and none of my classmates are here for this alumni function. Number two, although I was deputed by the Government of India to study nuclear medicine in Johns Hopkins Hospital in the year 1967, and I had the good fortune to be the first Indian to pass the American Board of Nuclear Medicine, but due to technical and other personal problems, I could not continue in the nuclear medicine, although I started the first isotope department in Medical College Hospital, Kottayam.
Thank you.
Third one is, so many people taught me and told me that I am a fool for coming back to India after 6 years of training in nuclear medicine and for the research in nuclear medicine. And I was the first batch group to start the research or to start the clinical trial of urokinase in pulmonary embolism. I was the head of the team and I published my first paper in New England Journal of Medicine, and Dr. Krishnadas, I will say, was my mentor, guide, teacher, and philosopher. With these few words, I thank the organizers, especially Panikar, for starting this oration, and I will never forget this. And also I thank Binu, although I couldn't teach him. I heard about him and I visited South Africa 2 times, but I never knew Binu was there. Thank you very much. Thank you very much for all the people. By God's grace, I can attend to next alumni meeting also, I think. Thank you.
Thank you, sir, very much. Now,
Thank you very much.
May I request Paulose, sir, to give the scroll of appreciation to Dr. Binu Luke. And please come for an official photograph, please.